Without further ado, which is a really good segue to our next talk by Dr. Eduardo Javier and Karen Antwiler about aging and with HIV and addiction, the challenges and opportunities. And just as a brief summary, Dr. Javier is a board certified in internal medicine and addiction medicine, serves as a program director for Eisenhower's Health as Fellowship Program in Addiction Medicine and at Eisenhower Charles Reckland Outpatient Treatment Center. He did a fellowship program in this specialty at Loma Linda Medical Center and at the Betty Ford Center. Dr. Karen Antwiler is board certified in family medicine and addiction, and she's very homegrown. She did a fellowship in addiction medicine here at Eisenhower Medical Center. So we're very proud and lucky to have them both. So without further ado, Dr. Antwiler and Dr. Javier.
Thank you, everyone, and good morning. Let me just orient myself here. All right. So we're going to be talking about aging with HIV and addiction, focusing on addiction. What are the challenges and opportunities? Again, my name is Dr. Javier, and this is Dr. Antwiler. We represent the addiction medicine department, and we have no financial relationships to disclose. So we aim to understand the epidemiology and trends of substance use disorders among older adults with HIV, and also to recognize the impact of substance use on HIV outcomes and aging-related comorbidities. We aim to identify specific substances and complications of these substances in terms of treatment success with HIV as well, and discuss the evidences-based management strategies and integrated care. So we all already have known and mentioned that there's an increasing number of people aged more than 50 and above living with HIV. 47% of HIV populations are aged 50 years old and above. They have longer survival rate now because of ART, and hence it includes and contributes to the multi-morbidity and polypharmacy. There's increased burden of because of longevity, there's increased burden of non-AIDS comorbidities such as neurocognitive declines, cardiovascular diseases, as well as psychosocial challenges. Substance use disorders are more common among HIV-infected individuals and than those who are not HIV infected. This is true among both young and older populations. A multi-study of older HIV-infected individuals with depressive symptoms found that 25% of them have admitted to reported use of substance in the past 60 days. Alcohol being number one, which is 20 to 30%, is still on the number one substance that is used. There's high prevalence in patients with HIV, followed by stimulants, which is 10 to 15%, and there's higher rate in patients with in MSM populations. Opioids are also, whether illicit or prescribed, increasing due to chronic pain. And the fourth one is cannabis. Cannabis is commonly used for symptomatic management, especially for pain, appetite, anxiety, and also sleep. All right, so there's a synergism burden of HIV, substance use, and aging, and there is a direct. Sorry. Oops, let me go back. Okay, thank you. There's a direct non-adherence treatment disparities. Adherence is poorest among individuals reporting polysubstance use. So this causes delayed in ART initiation, reduced retention in HIV care, and inferior HIV treatment outcomes. Number two is physical and mental impairment that disrupts regimen. And then the drug-drug interactions and reduced efficacy, pharmacological conflicts with ART, increased toxicity and decreased efficacy. And then we have the psychological and logistical barriers. So the lifestyle factors, the stigma and disclosure, as well as missed care. So it is very important to integrate substance use disorder with HIV care. So that's why we're very happy to co-manage a lot of our patients with our infectious disease department as well. So we're very lucky to have a very robust department that taking care of HIV patients. For our next slides, for specific substances and complications and treatments will be discussed by Dr. Antwiler.
So starting off with alcohol use and its interaction with HIV and aging, it is shown that patients who get diagnosed for an alcohol use disorder by the DSM-5 criteria, they are likely to engage in risky behaviors from intoxication, from withdrawal, and this in turn delays testing for HIV and it postpones care for HIV. In addition to that, there's also a difficulty in managing complex medications, and it also interferes with the pharmacological treatment with antiretroviral treatment management. On top of that, there are also a lot of medical complications that are associated with alcohol use disorder as well. So when you have alcohol use disorder-related liver disease, this negatively impacts HIV infection. And HIV patients are also co-infected with hepatitis C, and it's shown that patients who do have higher amounts of drinking, they perform negatively compared to their cohorts who have healthier drinking or abstinence. And HIV-infected patients are also at a higher risk of disease such as cardiovascular disease, cancers, and diabetes due to the immunosuppressive states. And in terms of psychiatric help or behavioral health, alcohol use disorder independently presents with depression and reduced quality of life. And when HIV is also added to this, there's an additive effect on depression, stress, and anxiety. And this is just kind of like an image to show that there's healthy aging, but when HIV is added to it, there's premature aging. And then when alcohol or alcohol use disorder is added to it, there's a highly more enhanced accelerated aging that's going on. So coming specifically to the neuropsychological and motor effects of HIV and alcohol use disorder, a couple of years ago, there was a study which showed that 52% of HIV patients often had cognitive deficits due to higher amounts of alcohol use. And when it came to specifically for testing for executive function, episodic memory, and processing efficiency, patients with HIV and alcohol use disorder did perform poorer, and age was a specific indicator of that. So there's a scatter plot diagram right here, which shows that as the age is increasing, the episodic memory is unfortunately decreasing. And this is also corrected for age as a factor in addition. And another study, which is from the Health and Retirement Study, showed that older individuals with HIV who were able to maintain their alcohol use at healthy levels or lower levels, they were less likely to develop functional limitations. And for someone who is 65 and older, the recommendation is 1 drink per day, 1 standard drink per day, or 7 drinks in a week. So coming on to the pharmacological treatment for alcohol use disorder, I'm not going to go into this in detail, but there are 3 FDA-approved treatments. The first is naltrexone, and it also comes in an injectable version known as Vivitrol, which is a once-in-a-month formulation. We have acamprosate, which is thought of as an amino acid, and it modulates that glutaminergic transmission. And then finally, we have disulfiram or Antabuse, which has been there for many years. And at this time, the 3 medications and the impact on HIV prevention and treatment is not studied. So coming on to the correlation of stimulants, HIV, and aging, stimulant use is very predominant among HIV-infected patients, and specifically among the MSM population. Unfortunately, older individuals are less likely to report the stimulant use due to stigma or fear. And with stimulants, there's this whole phenomenon known as the chemsex impact. So there's increased sexually risky behaviors. This can increase to the transmission of HIV, and of course, this extends to our older male population as well. And there are multiple complications that are associated with stimulant use. As you can see by this chart here, when you use meth, there can be risky behavior due to the intoxication, hypersexuality, disinhibition, and this often leads to new infection. And then when you are disinhibited or when you're under the or you're intoxicated, you don't take your antiretroviral treatment or you're not compliant with it. This leads to an increased viral load. And then meth by itself can trigger an inflammatory response and increase inflammation through production of more cytokines, chemokines, and human amniotic fluid factors. And this causes a whole immune dysregulation. And all of these factors can lead to a worsening of the HIV pathogenesis. And this is also compounded by the neurotoxicity of methamphetamine use, as well as the cardiovascular complications such as heart failure. So unfortunately, at this time, there are no FDA-approved treatments for the treatment of stimulant use disorder, but there are two medications that we commonly use off-label. The first one is bupropion or naltrexone, so Wellbutrin or naltrexone combination, and the naltrexone can be substituted with the Vivitrol injection. The second one that we commonly use is mirtazapine or Remeron. It helps through the calming of the serotonergic and the histamine response. But there are other medications that are being studied for stimulant use disorder. We also use topiramate or Topamax. Modafinil is being studied. The GLP-1s are thought to help with the regulation of the mesolimbic system. And there are also studies that psychostimulants such as Vyvanse can also be useful for the treatment of stimulant use disorder. So there is more to come. So at this time, the first-line care for stimulant use disorder is behavioral, so cognitive behavioral therapy and contingency management. Contingency management is when a patient comes in and they have a urine toxicology screen, it is negative, and they are given a gift card or a voucher. So the premise is that good behavior gets rewarded. So coming now to opioids, HIV, and aging. Unfortunately, this with opioids, it's kind of dual-ended. There's the issue of an opioid use disorder due to illicit opioid use, and then there's the issue of chronic pain. So coming to the opioid use disorder, as you all know, this is compounded by the advent of fentanyl. It's 100 times more potent than morphine, increased number of overdoses. At this time, it is unclear how fentanyl may contribute to or maybe limit HIV pathogenesis, but the thought is that it can impact the replication of HIV and increase chemokine co-receptor expression. So as a result, the thought is that when you have increased viral levels and you're using opioids like fentanyl, this will accelerate the disease progression. So that's the opioid use disorder part of it, but there's chronic pain is also very common in our HIV patients. It is shown there's a prevalence of about 25 to 90% of our HIV positive patients who are struggling with that. So on that note, more opioids are being prescribed for our HIV patients, and it's shown that about 21 to 53% of patients are prescribed, and this inadvertently can lead to an opioid use disorder, or this can lead to risky use and complications that can arise from opioids itself. So unfortunately, this is kind of like a double-edged sword. So coming on to the pharmacological treatment for opioids, there are 3 FDA approvals at this time. There is methadone, which is an opioid agonist, and this is specifically done only at the methadone clinics. The second is the buprenorphine. This is a partial agonist. It also comes in a long-acting injectable version known as Sublocade or Brixadi. And lastly, we have naltrexone. You can see a common theme here. Naltrexone is very helpful for substance use disorders, and it comes in the monthly injectable version known as Vivitrol. And at this time, both methadone and buprenorphine have shown to have a huge impact on HIV prevention and treatment. There's been decrease in injecting and needle sharing behaviors, increased retention and care, and there's also been increased adherence in antiretroviral treatment. So coming now to the specific substance interactions, when patients are on antiretroviral treatment, specifically the boosted antiretroviral treatments such as ritonavir or cobicistat, there's a huge interaction with chemsex drugs such as methamphetamine, cocaine, and GHB. The boosted antiretroviral treatments, what they do is that they inhibit the CYP3A4. And what this does is that it actually increases the amount of the illicit substances that are in the body. So what it does is that it can prevent them from leaving the system, such as amphetamines, and increases the levels to a toxic or more deadly level. So it potentiates the intoxication. As a result, there can be more complications from the intoxication and withdrawal. So coming specifically to stimulants, methamphetamine is metabolized by CYP2D6. And when it's given in conjunction with ritonavir, this increases more methamphetamine in the body and decreases the metabolism. And cocaine in particular actually increases viral replication and it impairs immunity. So coming to GHB and MDMA, it's the same thought process. So there's interactions with the protease inhibitor antiretroviral treatment. So when you use ritonavir or efavirenz, what it does is that it inhibits that CYP450 system and it increases the response of GHB or MDA in the body. So like worsening of hyponatremia or worsening overdose or respiratory depression. And then coming to opioids, there's 2 components to this. So as you know, there are adulterants in our fentanyl supply, such as tranq or xylazine or methamphetamine. And these are also substrates of CYP3A4. So again, you can see the theme when they're used with medications such as ritonavir or cobicistat. It increases the level of xylazine. It prolongs the half-life of xylazine. So not only does it make that opioid intoxication more potent, it can make overdoses happen quicker, and can also cause skin lesions due to the alpha agonism and vasoconstrictive effects. And then on another note, methadone, like I said, is one of the evidence-based treatments for opioid use disorder. Its levels can be reduced by medications such as efavirenz or other NNRTIs. Now, that does not mean that someone who's on HIV medications can't be on methadone. It's just that the methadone dose has to be appropriately regulated. It could be increased in response to someone being on HIV medications. So coming on to gaps and challenges, unfortunately, there's not much age-specific research when it comes to addiction and HIV. There's not a specific training track on geriatric addiction, and having that stigma and bias that older folks don't use substances doesn't really help our patient population. And on top of that, there are not that many integrated HIV substance use disorder programs for older adults. And just to kind of give an example of that, in the desert, there are only 2 inpatient rehabs that take patients who are on Medicare insurance, which is highly limiting. So that more work needs to be done on providing care for our patients who are 65 and older. And I'm gonna, this is my conclusion slide, I'm gonna leave it at this. Older people who are living with HIV, they do unfortunately face higher substance use disorder rates, and the complications range from just adherence to the medications to neurological problems, and along with medical comorbidities. And it's very important to screen and integrate care for this patient population. And something I want to really hone in on is that using substances is not a contraindication for prescribing antiretroviral treatment. And the best way to treat these patients is to combine evidence-based pharmacotherapy with behavioral interventions such as therapy or contingency management. And evidence-based treatments do exist, they do work, and unfortunately, they're not being as utilized as they should be. And in terms of HIV care for patients who are actively using, it might be better to use once daily formulations, medications that have higher barrier to resistance, lower chances of hepatotoxicity, and less drug-to-drug interactions. And my final point is that treating the substance use disorder will improve HIV outcomes and quality of life. Thank you.
We need to give them more time next year. I think that was great. Seriously, I think that's such a big topic here. So I think one of my jobs is to editorialize on all of this. As people are talking, I think one of our new faculty members, Dr. Lawrence Moore, who's back there, is joining us in March, and he and I have been talking about the overuse of sedative hypnotics, among our population, which is a big deal, and I know very important, but yet we just take it so lightly. And I don't think our patients, we've drummed that point in, and also alcohol appears to be a huge thing. Listen, I had my martini last night, so I'm not judging, but the point is there is overuse, and I know our patients are very worried about anti-inflammatories, and they talk about taking their turmeric as they're standing in line around the corner to go to the bars and arenas. So we need to educate our population exactly about what is going on. So I'm already getting ideas for next year's discussion here, and I hope you are too.